Hi everyone, welcome to our module on Principles of Oncology. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can do so with the link that is provided in the description. You can pay with a multiple number of payment methods available. Before we go into specific cancers, we need to understand the fundamental principles of oncology. Oncology is a study of cancer, how it develops, how it behaves, and how we treat it. So there are four major pillars that you need to understand. First is the molecular basis of cancer, like the what genetic changes has caused cancer. Secondly, tumor markers, how we track cancer in the body. Third is the grading and staging, how we classify cancer severity and spread. And finally, chemotherapy, how drugs target cancer cells. So at the core, cancer is a disease of genetic mutations. These mutations disrupt normal cell growth and lead to uncontrolled proliferation. Neoplasia means new uncontrolled cell growth. Normally, cell division is tightly regulated. But in neoplasia, what happens is the cells start growing independently without control. Now, we divide these tumors into benign and malignant tumors. Benign tumors are well organized. Their cells look similar to normal cells. They grow slowly and they do not invade nearby tissues or spread to distant sites. There is no invasion or metastasis. Whereas malignant tumors are very different. The cells look abnormal. They grow rapidly and they invade the surrounding tissues and they can spread to the distant organs. They can metastasize through blood or lymph. So that ability to spread or metastasize is what makes cancers dangerous. Cancer does not happen due to a single mutation. It happens because of multiple genetic mutations accumulating over time. Two main types of genes are involved. The first are called as the proto-oncogenes, which normally promote cell growth. Secondly, the tumor suppressor genes, which normally stop excessive growth. When proto-oncogenes become overactive and tumor suppressor genes stop working, the balance between this pro and anti genes is lost. So this imbalance leads to uncontrolled cell division and ultimately cancer. Now let's try to understand oncogenes in simple terms. Proto-oncogenes are normal genes that help the cells grow and divide. So when these cells are mutated, these proto-oncogenes turn into oncogenes. So this mutation makes them overactive, even when the body doesn't need that amount of growth. For example, RAS is a signaling protein. So when this RAS is continuously activated, it keeps sending growth signals through the GTPase. Whereas MYC is a transcription factor, it increases the production of proteins that are required for cell division. HER2 is a receptor on the cell surface. So when these are overexpressed, uh, it continuously stimulates cell growth. So these oncogenes are like stuck accelerator, like a stuck accelerator in accelerated pedal in a car. So whenever they're stuck, these proto-oncogenes normally maintain a baseline normal growth. But when you just give a push to the pedal, like something happens, like a mutation to these proto-oncogenes, and they uh, probably a gain of function mutation. They increase cell proliferation and lead to carcinogenesis. Now let's look at tumor suppressor genes. So these are nothing but the brakes of the cell cycle. They slow down or stop cell division when needed. But unlike oncogenes, both the copies of these genes must be damage for the cancer to develop. So this is also called as Knudson's two-hit hypothesis. It requires both the alleles to be inactivated. For example, TP53, also called as the guardian of the genome, monitors DNA damage. If damage is severe, what does this TP53 do? Is it triggers cell death. But when there's a loss of function mutation of this TP53, what happens is there is inhibited cell death, inhibited apoptosis, which leads to carcinogenesis. RB or retinoblastoma controls the transition from the resting phase to the DNA synthesis phase, controls the G1 to S phase transition. So in that way, this could lead to carcinogenesis. APC gene regulates pathways that control the cell growth through the WNT signaling pathway. So if these tumor suppressor genes stop working, cells just divide uncontrollably. Tumor markers are substances that are produced either by cancer cells or by the body in response to cancer. So a very important point is that tumor markers are usually not used to diagnose cancer. Instead, they are used to monitor the disease. For example, to monitor disease progression. So whenever you start treatment, we check if the marker level is decreasing or not. So it can be used as a prognostic indicator. If it rises again, it might indicate recurrence. Now let's discuss few tumor markers. One of them is alpha fetoprotein, which is normally produced during fetal development. So in adults, the elevation of alpha fetoprotein suggests possibility of liver cancer or certain germ cell tumors like yolk sac tumors. The other one is prostate specific antigen or PSA, which is used to monitor cancer, whereas CEA or carcinoembryonic antigen is associated with cancers of the colon and pancreas. So we need to remember that these markers are more useful for follow-up rather than just diagnosis. So these markers are mainly used as prognostic indicators and to check response to treatment. CA125 is commonly used in ovarian cancer, whereas S100 is a protein that is found in cells and is certain cells and is associated with cancers like melanoma and some nerve-related tumors like schwannoma and Langerhans cell histiocytosis. These markers helps us track disease progression. Immunohistochemistry is a technique that is used to identify specific proteins on cells. Like CD20 is a marker that is found on B lymphocytes. It is important because it is a target for a drug called Rituximab. So Rituximab therapy in B-cell lymphomas is targeted towards CD20, whereas chromogranin is found in neuroendocrine cells. It helps us identify tumors like small cell lung cancer and also carcinoid tumors. So this technique of immunohistochemistry generally helps us identify the type of cancer based on what protein is being expressed. So the key takeaway of regarding all these tumor markers is that they are not specific enough to confirm diagnosis, but they're extremely useful in monitoring therapy response. For example, if prostate antigen rises after treatment, it might indicate recurrence. And if the AFP levels rise after uh, fetal life passes or in adulthood, it might indicate liver cancer. And these AFP levels might help us in evaluating prognosis of liver cancer patients. It also helps us to detect recurrence and it is used for prognostic assessment. Now, coming to tumor grading. So, this grading tells us how abnormal the tumor cells look under a microscope. So, if the cells look similar to the normal tissue, the tumor is called as a well-differentiated tumor and is usually less aggressive. It has a slower growth and has a better prognosis. Whereas if the cells look very abnormal, the tumor is poorly differentiated and it's more aggressive. It has a rapid growth and it also has worse prognosis. So grading reflects how abnormal or how ugly the cells look. Staging tells us how far the cancer has spread in the body. So we use the extent of tumor spread. We use the TNM's system basically. So T stands for tumor size, N stands for nodal involvement, and M stands for metastasis. So staging is one of the most important predictors of prognosis. So we always need to remember that grading is something that's related to appearance, whereas staging is something that's related to evaluating the spread of the cancer. Chemotherapy targets rapidly dividing cells, but the problem is that the normal cells like bone marrow and gastrointestinal lining also divide rapidly. So that's the reason that chemotherapy has few side effects. So some drugs act only by acting during specific phases of the cell cycle, while others act regardless of the phase. So there are cell cycle specific chemotherapy drugs and cell cycle non-specific chemotherapy drugs. So different drugs act at different phases of the cell cycle. Now let's discuss about few anti-metabolites. One of those is methotrexate. Methotrexate blocks the production of folate, and we all know that this folate is required for DNA synthesis. So without DNA, the cells cannot divide. So, but this also affects normal cells, leading to bone marrow suppression, myelosuppression, and inflammation of the lining of the mouth, also known as mucositis. To reduce toxicity, we use a rescue agent called leucovorin that bypasses the blocked pathway. So, what does methotrexate do? It just inhibits dihydrofolate reductase and blocks the production of folate. We all know that this folate is necessary for DNA synthesis. And when it blocks DNA synthesis, it just doesn't inhibit the growth of the cancer cells, but it also inhibits the growth of the normal cells also. So this could lead to myelosuppression as a side effect and also mucositis. To reduce toxicity, we use a rescue agent like leucovorin, and this leucovorin helps us bypass the blocked pathway of the folate synthesis. Now coming to 5-fluorouracil, this drug blocks an enzyme that is required for DNA synthesis, and that enzyme is thymidylate synthase. Previously, with methotrexate, that was dihydrofolate reductase, whereas with 5-fluorouracil, it's thymidylate synthase. It is concerned with thymidine synthesis. Without this enzyme, the cells cannot replicate. So, a characteristic side effect is the damage to the skin of the hands and feet, also known as hand-foot syndrome, which causes redness and pain. The other side effect is mucositis. So this 5-fluorouracil is very commonly tested. Now let's discuss about few alkylating agents. One of those is cyclophosphamide. This drug damages DNA by forming crosslinks. It crosslinks the DNA and prevents replication. However, it produces a toxic byproduct that generally accumulates in the bladder and leads to hemorrhagic cystitis. This can cause bleeding from the bladder lining uh, because of a toxic metabolite called acrolein. So, to prevent this, we give a protective drug that neutralizes the toxic compound acrolein. So that preventive drug is called as MESNA. So this, what does this MESNA do? Is it binds acrolein and protects the bladder in patients who use cyclophosphamide. So MESNA should be used alongside cyclophosphamide therapy. We will also discuss about few anti-tumor antibiotics. A few of them are doxorubicin and bleomycin. Now, coming to doxorubicin, it damages the DNA by generating free radicals, and we all know that whenever free radicals are produced, it could lead to DNA damage. So these free radicals can also damage the heart, leading to heart failure. So we use a protective agent to reduce this toxicity. So that's called as dexrazoxane. Dexrazoxane. Okay. So while coming to bleomycin, this also causes DNA damage, but mainly it affects the lungs. leading to the main side effect of bleomycin is pulmonary fibrosis. So we always need to remember organ-specific toxicity. Doxorubicin is concerned with dilated cardiomyopathy, whereas bleomycin, the side effect is pulmonary fibrosis. In doxorubicin therapy, we need to give a dexrazoxane alongside to prevent uh, toxicity. Doxorubicin, dexrazoxane, dilated cardiomyopathy. Now, coming to microtubules and microtubule drugs that target the microtubules and also the platinum drugs. So, vincristine prevents cells from dividing by disrupting the structures that are required for cell division. Like it just inhibits microtubule formation, but it also affects nerves, leading to peripheral neuropathy. Whereas cisplatin damages DNA and can harm the kidneys and ears, leading to nephrotoxicity and ototoxicity. So, to reduce toxicity, we use a protective agent alongside cisplatin. So, that's called as amifostine. So, the key pattern is drug, mechanism, toxicity, and antidote. So, some of the few drugs that we have discussed till now, we have all followed all of them in the same pattern. Vincristine is concerned with uh, inhibition of cell division by inhibiting microtubule formation. The main side effect is peripheral neuropathy, whereas cisplatin, the mechanism of action is by cross-linking the DNA molecules, and this leads to side effects like nephrotoxicity and ototoxicity. For preventing cisplatin toxicity, we use amifostine. Now, let's just quickly summarize this module. So, oncogenes are nothing but the genes that arise from a gain of function mutation of the proto-oncogenes. So few of them are RAS, MYC, and HER2. Whereas tumor suppressor genes, whenever they undergo a loss of function mutation, what happens is there is inhibited apoptosis, and the examples of those tumor suppressor genes include TP53, RB, and APC. Tumor markers are mainly used for monitoring and they're used as a prognostic indicator. They're not specifically made for diagnostic purposes. Grading is used to identify the level of differentiation, whereas staging is used to evaluate the spread of a tumor. Now, let's also quickly summarize, discuss few drugs. Methotrexate. Whenever we give methotrexate, we need to consider using leucovorin as a rescue therapy to prevent myelofibrosis. Whereas cyclophosphamide is concerned with hemorrhagic cystitis because of a toxic protein called as acrolein. And the preventive therapy that we have to use alongside cyclophosphamide treatment is a drug called as mesna. Doxorubicin is concerned with dilated cardiomyopathy, cardiotoxicity, and the preventive drug is dexrazoxane. Bleomycin could cause pulmonary fibrosis. Vincristine is concerned with peripheral neuropathy as a side effect, and cisplatin could cause nephrotoxicity and ototoxicity. And the preventive therapy that we have to use alongside cisplatin therapy is amifostine. I hope this video helped you. Before ending the video, I would like to let you know that we'll end the hematology and oncology series very soon with a last video covering all the miscellaneous topics. Thank you so much. Bye.